I start? Good morning, esteemed judges. I am honored to present Bang, a novel low-cost mix which shows promise for lowering IOP. It's not working. नहीं. Okay. I have no financial interest in the study. As we all know, the major site of resistance to aqueous humor outflow is at the level of juxtacanalicular trabecular meshwork, and excising or removing a strip of TM gives us direct access to the Schlemm's canal. So what is Bang? It is a minimally invasive glaucoma surgery with an ab interno approach. It utilizes a 25, 26 or 30 gauge bent needle to de-rough the Schlemm's canal in the nasal quadrant. Bang is also called as poor man's kahook. And why the fuss about Bang? Because the best thing is everyone can do it. We have cataract surgeons who can do it, retina surgeons who can do it, and even a glaucoma fellow asked the senior if they can try their hands on Bang in the early stage of fellowship. So it was brainchild of Schut et al., who in 2019 described 100-degree goniectomy at nasal angle using 25-gauge bent needle. He observed more than 20% reduction in IOP and more than 1 drop in AGM in 6 months, but the study was limited in open-angle glaucoma. So we conducted another study to assess the safety and efficacy of Bang in open-angle and oppositional angle closure glaucoma eyes undergoing phacoemulsification. We included 32 eyes of 26 patients with IOP more than 21 millimeters of mercury and significant cataract. The baseline evaluation included best corrected visual acuity, IOP, gonioscopy, cataract grading, optic nerve head evaluation, optical biometry, and automated perimetry. So among these 32 eyes of 26 patients, we had an average age of 64 years, 69.2% males, 30.8% females, 0.75 was the average CD ratio, and the average CCT was 530 microns. We included 47% of open angle glaucomas, 34% oppositional angle closure glaucoma, 13% pseudo-exfoliations, and only 3% pigment dispersion and ocular hypertensives. Among the severity, we included 22% mild cases, 37% moderate cases, and 41% cases of severe glaucoma. A single surgeon performed all the surgeries under peribulbar block sitting temporally. A 25-gauge needle was bent to 90 degree and used to excise the nasal 100 to 120 degree of TM before performing phacoemulsification. Postoperative care included topical antibiotics and steroids, and pilocarpine 1% was observed for 4 weeks. Follow-up visits were scheduled up to 6 months. These are the results. Our primary outcome was to achieve target IOP with or without anti-glaucoma medication. So this was achieved in 85% cases of mild glaucoma, 91 in moderate cases, and 38% of severe glaucoma. The overall success rate was 84%. These are the changes in IOP at different time points during the study. So to begin with, it was around 26.3. It dropped down to 15 on post-op day 1, but we could see a rise in IOP at post-op day after 1 month of the surgery. This is where we started adding AGMs to the patient. The secondary outcome was reduction in the number of AGM more than 1. So this was achieved in 71% cases of mild glaucoma, 83% of moderate, and 53% cases of severe glaucoma. These are the changes in the number of AGM at different time points during the study. To summarize, we had baseline IOP of 26 millimeters of mercury, which dropped down to 14 at 6 months. We had 2.6 AGMs to begin with, which dropped down to 1.6. So more than 30% reduction in IOP was achieved in 84% of our cases. We achieved 100% success in open angle glaucoma, but only 54.5% success in oppositional cases. So it is actually a very safe procedure when we compare to traditional bleb forming surgery or wall surgery, but still we encountered transient hyphema in 8 cases which resolved on its own, fibrin in 2, PAS in 2, and steroid response in 1. We had 5 patients who did not achieve the target IOP after Bang, and only 1 patient required additional filtration surgery. So when we compared our papers to the others, we included open angle as well as angle closure glaucoma cases. We included all mild, moderate, and severe cases. We achieved a 43% decrease in IOP from baseline at 6 months, and there was decrease in AGM in 59% of our cases. If we compare open versus angle closure glaucoma, we had 65% success rate in the open angle and 50% success rate in the oppositional closure glaucoma. Limitation, we have a small sample size with short follow-up duration, lack of control group. It was a single surgeon, single center study. My take-home message is Bang plus phaco is a very safe and effective mixed technique. It is an attractive, cost-effective option for developing countries like India and Africa. Bang is best suitable for mild and moderate open-angle glaucoma. The results are comparable to more expensive mixed devices like KDB, eye stent. Further research is needed to confirm the findings of Bang in angle closure disease. Thank you.
Good presentation.
Thank you, sir.
So why, if sir, आप पूछिए sir.
So why do you think your success rates were lesser in the angle closure glaucoma subgroup?
Sir, majority of our angle closure cases were severe glaucoma. So anyway, the success rate was lower in severe glaucoma because the distal collector channels are not believed to open after the bang surgery in severe cases. 2 patients developed pars and angle closure diseases only. So maybe that's why.
So, but did you do subgroup analysis? Because if you can't compare apples with oranges, you can't compare a severe group with a mild group. So, was there subgroup analysis also done?
No, sir.
Okay.
I can add it in my study next time.
Which gauze needle you used for the surgery?
So, ma'am, we used 25 gauge needle.
For the all patients?
For all patients.
Any incidents?
IOP increased after 1 month.
Yes, sir.
And it again increased after 2 months, according to data.
No, sir.
You started.
We started.
Medication.
Yes, at 1 month when we observed if the patients did not achieve the target IOP, we started adding AGM one by one depending upon the follow-ups.
So if the IOP increases again, then you can do the surgery next or?
Yes, sir. So sometimes we do only 90 degree. So we can again do the remaining 90 degree. Yes, next 90 degree. Yes, because all the nasal quadrant we tried inferonasally first because that has the maximum amount of distal collector channels, but we can also try superonasally.
You mentioned in your take-home messages that this outcomes are comparable to the modern stent devices, but your paper does not have any results like that.
Okay.
So you cannot extrapolate that from your paper, isn't it?
Any difference in success rate of between primary open angle glaucomas and pseudo exfoliation?
No, sir. We had only 3% cases of pseudo exfoliation, and open angle glaucomas we had around 39%.
Did you observe anything different?
No, sir. The success rate was similar in both the cases.